So thank you, Dr. Katz. We will go ahead and get started, and I will introduce you, and then you can start with your slides. So Dr. Daphna Katz is an assistant professor at Montefiore Einstein. Dr. Katz's clinical practice centers on pediatric nutrition, feeding disorders, malnutrition, and obesity. After obtaining her Bachelor of Arts degree from Georgetown University in 2012, Dr. Katz earned her Doctor of Medicine at the University of Maryland in 2017. She completed her pediatric residency at the University of Miami in 2020 and her pediatric gastroenterology fellowship at the same institution in 2023. Her research interests are in advancing infants and children's nutrition and in pediatric quality improvement. She has shared her work through several peer-reviewed journals, numerous abstracts, and invited presentations. Dr. Katz is board certified by the American Board of Pediatrics. She is a member of the American Academy of Pediatrics, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and the American Society for Parental and Enteral Nutrition. Welcome, Dr. Katz.
Oh, sorry, if it's okay for you to just come back. Oh, sorry about that. Thank you very much for the introduction, and thank you to everybody who's logged on tonight. I joined the Division of Pediatric GI at Montefiore last month. I see patients with general GI conditions, but I'm especially interested in pediatric nutrition, which is what I'll be talking about tonight. Within pediatric nutrition, I'm going to focus on three main areas. The first is obesity, then I'll talk about malnutrition, also known as failure to thrive, and I'll finish off with some general dietary advice for families of patients who are an ideal body weight. Pediatric obesity is an epidemic within an epidemic. There's currently over 14.4 million children in the United States who are obese, and that prevalence is rapidly growing. In the 1960s, 5% of children were obese, and that's more than tripled in the 2010s to 19%. So currently, about 1 in 5 children are obese. Based on that trend, it's projected that 57% of children currently aged 2 to 19 years will be obese by the time they reach 35 in 2050, which is a pretty scary projection. And part of how this became such a large problem is as a result of COVID. Some analyses predict that some analyses have shown that the rates of pediatric obesity have doubled from the pre-pandemic to the post-pandemic era. Obesity is a pretty nuanced issue. It occurs as a result of more than just genetic predisposition and environmental factors. We understand that there's a large socioeconomic impact on obesity, as we see that children who are in poverty are much more affected by obesity. Obesity is most prevalent among Hispanic children and non-Hispanic Black children, and children and youth with special healthcare needs have a higher prevalence of obesity, which can be a pretty challenging population to manage. So in light of the growing crisis, the American Academy of Pediatrics set forth some pretty comprehensive obesity guidelines just this year in 2023. And these guidelines were put together by subspecialists from multiple different areas within pediatrics that all came together and recommended that we should be treating obesity very early on, and treatment needs to be longitudinal for these patients. So as pediatricians, all committed to minimizing health disparities and protecting children's health, it's kind of a call to all of us that we need to be involved in combating this crisis. So when talking about obesity, it's important to be familiar with and understand the definitions. A BMI of greater than or equal to the 85th percentile is consistent with being overweight. A BMI of greater than or equal to the 95th percentile is consistent with being obese. And severe obesity refers to a BMI of greater than or equal to 120th of the 95th percentile. And what that's referring to is something called an extended BMI chart, which is a specialized tool that was developed by the CDC to better help analyze patients who have a BMI greater than the 95th percentile. So it incorporates extra data. And the reason why it's important to be using an extended BMI chart for patients who are obese is because when you reach the top of the standard curve, it's difficult to appreciate differences once a patient is above the 95th percentile. So here I've included an example of a patient's growth chart, and this is the same patient. On the right, you have a standard growth chart, and you can see that all of the numbers at the top, all the data points appear to basically be unchanged. And so if you were to just look at that growth curve, you wouldn't appreciate the differences that this patient actually, in the last few years, initially their BMI was above the 99th percentile. And over time, the patient actually had some significant improvement with a BMI closer to the 95th percentile. So yes, that patient is still obese, but they have made some significant changes, and it's important to track that so that you can motivate your patient and be monitoring their progress appropriately. When evaluating a patient with obesity, in addition to always reviewing growth curves, reviewing their diet, one of the main parts of visits with obese patients is screening for comorbidities. The main comorbidities that are recommended for screening include non-alcoholic fatty liver disease, hypercholesterolemia, type 2 diabetes, hypertension, obstructive sleep apnea, and psychosocial issues. And it's important to be screening for comorbidities, not only because we know that patients with obesity are more prone to these issues, but also because it helps you understand the severity of a patient's obesity and how aggressive you should be in their management. So, for example, if I see a patient who is obese, has stage 2 fibrosis, and has obstructive sleep apnea, that's going to ring a lot more alarm bells for me than a patient who is overweight. And that's going to be a patient that I'm going to be a lot more aggressive with management. So I'll start off with non-alcoholic fatty liver disease, since that's generally something that we focus on more in GI. So non-alcoholic fatty liver disease, or NAFLD, is an umbrella term that refers to patients who have greater than 5% infiltration of the liver with fat, either by advanced imaging or histology, and this has to occur in the absence of alcohol intake, genetic diseases, or medications that cause steatosis. So within this umbrella term, patients can have NAFL, so just fatty liver, and that's bland steatosis, or patients can have NASH, which is steatohepatitis, where now the fat within the liver is actually causing inflammation and hepatocellular injury. And this can occur with fibrosis, or this can occur if fibrosis is ongoing, it can actually end up leading to cirrhosis. So that's an important distinction, because fibrosis is something that's a process that's still reversible, whereas once a patient becomes cirrhotic, that's no longer a reversible process, and that would probably end up requiring liver transplant. So that's something that you want to emphasize to your patients, that even though they feel fine, they may be asymptomatic, that obesity is very serious and can end up resulting in needing a liver transplant. NAFLD occurs in about 34% of obese children, so nearly 1/3 have NAFLD of obese children. And the prevalence of pediatric NAFLD is higher among obese Hispanic males with prediabetes or type 2 diabetes. We also know obstructive sleep apnea and hypopituitarism are risk factors for NAFLD. So these are definitely patients that you want to have a high suspicion for NAFLD. But you can't just assume that a patient who has an elevated ALT and is obese for sure has fatty liver because it is a diagnosis of exclusion. So we can suspect it, but ultimately we have to rule out other causes of transaminitis, and the gold standard for diagnosis is a liver biopsy. Unfortunately, there's no available medications for NAFLD. The mainstay of treatment is lifestyle modifications and dietary modifications. But again, we need to be following these patients closely to make sure that they're not becoming cirrhotic. And NASH-related cirrhosis is now the second leading cause for liver transplant in adults. So just as a reminder, I've included the upper limit of normal for ALT for boys and girls because often when we check labs, a lab won't flag an ALT as being abnormal when really anything above 26 for boys is considered elevated, and 22 for girls is considered the upper limit of normal. So anytime a patient has an elevation in LFTs, it should be followed and should be further investigated. So moving on to the next comorbidity, hypercholesterolemia. Again, this is something that we know patients with obesity are more prone to develop. And the reason why we want to be screening for this is because we know that cardiovascular disease can also lead to high morbidity in patients. Universal screening for all pediatric patients is recommended between the ages of 9 to 11. There were also guidelines that were put out for this a number of years ago recommending universal screening. And this can be done sooner for patients who are high risk. So for patients who have a strong family history of hypercholesterolemia. When screening for hypercholesterolemia, a fasting lipid panel is preferred for specifically checking triglycerides, and ideally it should be fasting with 8 to 12 hours before. But if you have a patient that you have in your office that you think it'll be difficult for them to come back for labs and you are concerned that they have high cholesterol, you can obtain non-fasting lipids and specifically look at the non-HDL cholesterol, which will still be reliable even if your patient's not fasting. The most common pattern of dyslipidemia that we see in patients who are obese is elevated triglycerides, a low HDL, and an elevated LDL. And again, similar to fatty liver, the mainstay of treatment is diet and exercise. There is some evidence to suggest that omega-3 fatty acids are superior to placebo when patients have elevated triglycerides. But statins are really only recommended for patients with persistent elevations or for patients who have a really strong family history of hypercholesterolemia. And here I've included the normal ranges, just as a reminder that pediatric ranges are different from adults. So you want to make sure to be looking at the pediatric guidelines published by the National Heart and Lung Association. And if you want to remember just one number for triglycerides and LDL, you can remember the number 130. Anything above that is going to be abnormal. And for HDL, less than 40 is considered abnormal. So the next comorbidity is type 2 diabetes. This is something that we also want to screen for in all of our obese patients. Again, for patients who are 10 years and older, so similar to cholesterol, which is age 9 to 11, it's around the same age that we're screening for diabetes. And you can also screen for patients who have a strong family history or anyone who has signs of insulin resistance, like acanthosis, should be screened, or patients who have use of obesogenic psychotropic medications. We screen using fasting plasma glucose, a 2-hour plasma glucose after an oral glucose tolerance test, or hemoglobin A1C. And, primarily this is managed by endocrinologists, but the reason why it is important to screen for diabetes in patients who are obese is because that opens up our options in terms of medication management that we can use for obesity and for non-alcoholic fatty liver disease, because there are no approved medications specifically for those indications, but it can be helpful if a patient is confirmed to have diabetes or pre-diabetic to utilize those medications for weight loss as well. And I'll go into that a little bit more later in the presentation. Then you also always want to screen patients for hypertension. As we know, obesity is the strongest risk factor for hypertension in childhood. When you're screening, you want to take a history of salt intake, physical activity and inactivity, and sleep disturbances. And there also were guidelines that were published by the AAP in 2017 that outline how to classify hypertension. I won't really go into these in detail, but just a reminder that when you are screening obese patients, you want to make sure you're using an appropriately sized blood pressure cuff. Obstructive sleep apnea is also a very important comorbidity to screen for, because this is something that we actually can intervene on. So if you have a patient that screens positive for obstructive sleep apnea, you want to make sure that you're referring them for a sleep study, because they could actually qualify for a CPAP, which will make a difference for these patients. So this is one comorbidity that we can actually intervene on. And the prevalence of OSA among obese children is 45% compared to 9% of children with a healthy weight. So this is actually occurring pretty frequently in patients who are obese. It's associated with cardiovascular complications, neurocognitive impairment, and decreased quality of life. The common symptoms that you'll get from patients with OSA are that they'll have loud snoring. If you ask the parents, they'll actually say that they hear them stop breathing overnight. They will have inattention or sleepiness or learning problems. So these are all patients that you want to make sure to be sending for a sleep study. The last comorbidity that we generally screen for is psychosocial issues. And there's debate over which one occurs as a result of which, whether patients who are obese are more prone to depression versus if depression ends up making patients be at a higher risk for developing obesity. But regardless, it's important to be screening for psychosocial issues and referring patients to psychology or psychiatry, because if you really want to have a successful weight management program, then it's very important for patients to be in the right state of mind. You won't be able to make really significant lifestyle modifications and really effectively change a person's diet if they're very depressed and not in the right headspace. So this is something that's really important to be addressing if you want your patient to be successful in an obesity program. So in terms of obesity management, in addition to screening and following comorbidities, the mainstay of treatment is lifestyle and dietary modifications. And this has to be a coordinated approach. It has to be family-based, and we need to be employing long-term strategies. So what this means is that this isn't going to be as a result of the effort of just one pediatrician. It's probably going to be a team effort where it's multiple subspecialists involved in a patient's care, ideally having a dietitian involved, some social work, psychiatric involvement are all important to really successfully help a patient with obesity. A family-based approach is very important, because oftentimes we'll ask patients about their diet, and parents will say, I try to give them just the healthiest foods, but then they sneak into the pantry and take snacks. So then the question is, well, who buys the snacks? How did they get into the house in the first place? So the approach to helping an obese child is going to be much more successful if it's a whole family effort and the family working together to be healthier and to change their lifestyle. And this can't just be one visit and then no follow-up. It has to be carried out long term to make sure that patients really change their lifestyle. Every patient is going to be different. There's no one size fits all. What works for one patient may not be an effective strategy for another patient. And that's partially because of the strong effect of socioeconomics that you have to take that into consideration when you're making a treatment plan for each of your patients of how available are healthy food options, how easy is it for them to exercise, how much time do parents have to really be preparing meals? So these are all things that will have to be done on an individual basis. There's data to suggest that motivational interviewing is very successful for patients with obesity, that you want the goals to be coming from the patient. So when you talk to the patient, you want to figure out what are their priorities, and more than just what is the number of a weight that they want to see, you want to really understand what change do they want to see. Do they want to not be bullied at school? Do they want to feel healthier? Do they want to be able to participate more in gym class? What is it that is going to motivate them to really make changes in their lifestyle? So a lot of research has gone into the factors that make an obesity program successful. So in addition to some of the things I've mentioned already, there are other factors like increased frequency of visits. So these are patients that you don't want to space out your visits of follow up in 1 year or 6 months. These are patients that you want to be seeing frequently. So sometimes in the beginning, you may want to see them once a month until they are really showing signs of changing. And then you maybe can space out to every 3 months, but making sure that you're really following these patients closely and keeping them motivated. You want to make sure that your expectations are aligned, that they're part of a medical home, as I mentioned, with multiple subspecialists being involved in their care. So just some general dietary advice. So some of the more obvious things and maybe simpler things to suggest to patients. So initially, just eliminating all sweet and sugary beverages in patients' diet, no juices, no sodas. And this can be a surprisingly effective strategy. It may seem very simple and obvious, but for some patients, it's really not obvious, and you'd be surprised actually how much patients consume in calories just from beverages. So if when you're starting with a patient that maybe changing their lifestyle seems extremely difficult, you can just give them the simple goal of completely eliminating sugary and sweetened beverages and tell them that they have to follow that goal very strictly, and you may see that actually that can result in some significant changes. Another simple goal is just going over how the plate should be divided. And you can recommend that they look at the choosemyplate.gov, which actually suggests recipes and has a lot of meal ideas for patients. And again, you'd be surprised at how helpful just organizing a patient's plate at meals can be for achieving their long-term goals. So some additional pearls that I like to share with patients. Number one is replacing unhealthy foods with fruits and vegetables. So you might suggest to a patient that whenever they feel a craving, they should just reach for a fruit or a vegetable. And also maybe suggest if they like eating something like Cheetos, as opposed to eating a full bag of Cheetos, anytime they take a handful of Cheetos, they should pair that with a handful of carrots. So anytime they eat something unhealthy, pair it with something healthy. They have a craving to crunch on something like like chips, reach for grapes instead. That this can be a way to satisfy craving just by increasing fruits and vegetables, and nobody will get obese from just eating a ton of fruits and vegetables. Another goal that can be helpful to patients is eliminating, ideally, or minimizing the use of condiments. So, in that way, maybe they wouldn't have to change anything in their diet if they make a sandwich just by taking out the mayo or any of the condiments that they're using. If they eat a salad, taking out the dressing or limiting the amount of dressing, that can make a very significant change in the total caloric intake that a patient has every day. Another goal to suggest to patients, and this one may be easier said than done, but just preparing food and eating at home as much as possible. So when you eat at home, you control directly what you're putting into your food and your portion size as opposed to eating out. Patients will often end up eating a lot more maybe than they need to be satisfied. So eating at home can be a really important and helpful strategy for weight loss. Also, buying whole food. So, when patients are in the grocery store, buying anything that is more closely resembling the food is going to be healthier. So, for example, instead of buying chicken nuggets, buying the regular chicken is going to be a lot healthier for patients. And finally, avoiding fried food. Anytime there's a cooking medium that's going to end up creating more fat, and just trying to grill instead of frying can be another strategy that's helpful. So, generally, when I see a patient, I might suggest a few of these things and ask them, what do you think would be the most feasible goal for you? Based on your lifestyle. So I'll recommend that they'll pick one goal initially and stick to that goal for at least 1 month. And I'll suggest to patients that at the end of that month, if it feels terrible, it feels like that goal was not helpful and was not compatible with their lifestyle, then we can pick a different goal. But often, what patients end up seeing is that if they just stick to something for a full month, by the end of the month, they will feel like that's natural and it's not a difficult change anymore. So instead of giving patients a very overwhelming weight loss plan, just by sticking to one or two goals at each visit at an interval of 1 to 3 months, can end up leading to them making a lot of significant and impactful changes. In terms of exercise, the data shows that the impact of exercise is not quite as strong as dietary changes, but it's still important to recommend that patients are physically active. And again, this can be challenging for some of our patients that don't have a safe space to exercise. But what I'll recommend to patients is that even in their homes, if they have stairs or in an apartment building, just choosing the stairs over an elevator, going up and down the stairs for 30 to 60 minutes can be a helpful way to just stay more active. Trying to do crunches, push ups, squats within their home, even if it's a small space, can make a difference. So, any amount of physical activity is better than inactivity. And it's just time that also is spent away from screens, whereas in front of screens, patients generally end up eating more. So this can be a way to just get patients away from screen time. So, in terms of treatment options for obesity, as I said, the mainstay is lifestyle and dietary modifications, but there are scenarios where for patients that's just not enough. And in those cases, we do consider pharmacotherapy. So, examples of this may be obese children who have more immediate and life-threatening comorbidities. So, for example, for patients that already have advanced fibrosis, these would probably be patients that we're considering pharmacotherapy, where we feel like diet and exercise alone is just not going to be enough to prevent them from progressing towards liver transplant. Other patients that we start considering weight loss medications for are older children with more severe obesity. So, like the patients that have are plotting on the extended BMI curve with really severe obesity. These are patients that we may be considering pharmacotherapy as well, because if you have a patient that's already over 300 pounds, even if they lose 10 pounds, they're still very severely obese. So they may just need something extra to help them with weight loss. And the final group of patients that we start considering medications for are those who have minimal improvement with intensive health, behavior, and lifestyle treatments. So, for example, if we have a patient that we've been following for 3 years, say they came to us when they were 14, now they're 17, and over that time they made very minimal changes, we might say this is a patient that now we think would benefit from pharmacotherapy. But anytime we're prescribing weight loss medications, it's always with the thought in mind that this is ideally not something that's going to be long term. It's just going to be a tool that will help us more quickly see the results that we want to see, and that over time will help patients change their lifestyle and they won't need medications to have sustained healthy behaviors. We don't have that many options at this point, but this is a rapidly evolving field. The current medications that we most commonly use are metformin. So as everyone knows, this is an anti-diabetic drug used in children with type 2 diabetes who are over 10 years, and it works by improving insulin sensitivity. In terms of obesity, it can be helpful to curb appetite. So we may recommend that patients take it 2 or 3 times a day before meals. The limiting factor will be GI side effects, so that will prevent us from dosing it more frequently if patients are developing nausea from metformin. For sure, any patient that's screened positive for prediabetes or diabetes should be on metformin, but sometimes we'll even consider metformin for patients who maybe don't have an A1C in the pre-diabetic range, just if they are in one of those categories that I mentioned of having very minimal progress from weight loss strategies without the use of pharmacotherapy. Another medication that we can use is orlistat. This is an intestinal lipase inhibitor that's approved for children 12 years and older, and it works by blocking fat malabsorption. So the side effect that we end up seeing from orlistat will be diarrhea, and this may limit its use long term as well. Orlistat has debatable efficacy. For some patients, it may work. For many patients, it doesn't work, but it is something that we can try, especially if they have too many GI side effects from metformin. And the newer medications are the GLP-1 agonists, that these work by slowing gastric emptying and act on targets in the CNS. They're approved for obesity in children 12 years and older, and I know there's been a lot in the media about GLP-1 agonists. So these don't have as much long-term data. They're relatively new, but studies, at least preliminarily, are showing that they are effective in children. And here I've included, this is a meta-analysis that was published in the Journal of Pediatrics earlier this year, that basically evaluated the safety and efficacy of glucagon-like peptide receptors. And the goal of this meta-analysis was to determine what effect these medications have on children, specifically with obesity. This meta-analysis included 9 randomized control trials that involved 574 participants. And what they found was that these medications do cause a modest reduction in BMI, in BMI Z-score, and in glycemic control. There was no improvement seen in lipids, but there was also a moderate decrease in systolic blood pressure. The main side effect that was seen was nausea, but no other GI side effects. So the authors concluded that GLP-1 receptor agonists are safe and are effective for reducing weight, BMI, hemoglobin A1C, and systolic blood pressure in children. And I suspect that we're going to be starting to use these a lot more in children with obesity in the future. Another option in addition to medications is bariatric surgery. There was an AAP policy statement that was published in 2019 that concluded that weight loss surgery is safe and effective for pediatric patients who are in centers who have experience with youth. Bariatric surgery is indicated for pediatric patients who have a BMI of greater than or equal to 35 with comorbidities, or a BMI of greater than or equal to 40 with or without comorbidities. Often patients with a BMI that high will have comorbidities, but it's not a requirement for bariatric surgery. And the idea behind doing bariatric surgery in pediatrics, while in some ways sort of seems contradictory to our general approach in pediatrics, where we generally try to avoid surgery for our patients when possible. But the thought is that if we combat obesity early on, if we don't wait for complications like liver cirrhosis to occur and we address this issue from an early age, we may give patients a better chance at having a healthier adulthood. So this is still something that we're evaluating what the best timing is for bariatric surgery, but that is something that people feel is that maybe that is what makes the most sense, is to be referring these patients earlier on before they develop significant complications. When referring patients for bariatric surgery, the two most common procedures now are the laparoscopic Roux-en-Y gastric bypass and the vertical sleeve gastrectomy. We no longer do the band procedure. That's kind of fallen out of favor because that had a higher risk of complications, whereas these two that I've mentioned have very minor postoperative complications. The main thing that's important for these patients' care is long-term to monitor them for micronutrient deficiencies. But in the short term, patients usually do pretty well post-bariatric surgery, even younger patients. So now I'm going to completely switch gears to pediatric malnutrition, also known as failure to thrive. Um, the reason I included the term failure to thrive is because this is what we're most used to hearing, but actually there's a movement now to no longer refer to pediatric patients with malnutrition as having failure to thrive. And now we have malnutrition indicators, which I'll go over on the next slide. But because not everybody has moved away from that, I'll talk a little bit about what we mean with failure to thrive. So generally, this is referring to patients who either have a weight or weight for height that's less than the third or fifth percentile, or for children who are older than 2 years, we use BMI. This may also refer to patients who have a downward crossing of more than two major percentile lines, or it could refer to patients with a z-score, so standard deviation of -2 or less for weight for age, height for age, weight for height, or BMI. So these are the new indicators for malnutrition. So as I said, we're no longer really looking at percentiles, and now the focus is on z-scores. And we categorize patients as having either mild, moderate, or severe malnutrition. And whereas previously we used the -2 z-score as our benchmark, now it's become more nuanced, where we actually look at the differences in the z-score to determine how severe patients' malnutrition is. If you only have one data point, malnutrition is classified just using weight for height, BMI for age, height for age, or mid upper arm circumference. When you have two or more data points available, you can actually look at the velocity of weight gain, weight loss, a decline in weight, or inadequate nutrient intake. And these are all important to be using in terms of billing, and actually using the correct ICD code. So you want to look at those indicators in order to bill appropriately and get patients the resources that they need based on their degree of malnutrition. So when you're evaluating a patient with malnutrition, You want to distinguish whether this is acute or chronic. So, in a patient who is underweight for height, that's a marker of acute inflammation. So, generally, patients will preserve their height even if they're initially malnourished. And only if that process goes on long term, they'll eventually become stunted, where now they'll have a below normal height for age. And that's a marker of chronic malnutrition. When you're evaluating a patient with malnutrition, you want to think about what the cause is, and that generally will fall under three different categories. So, either the patient has excessive caloric losses. So, for example, this could be a patient with undiagnosed inflammatory bowel disease where they may have a normal caloric intake for age, but because of excessive GI losses, they're not able to maintain their weight. And initially, they may maintain their height, but just be small for their height. And if that goes undiagnosed for a long period of time, they'll eventually get stunted as well. Patients may not have excessive losses, but they may just have increased energy needs. So that could be a patient with an unrepaired cardiac defect, with cystic fibrosis. These patients are just going to need huge amounts of calories to maintain a normal weight for age. And finally, this is probably the most common one that we all encounter is going to be insufficient intake, where a patient doesn't have any extra losses, they have no other medical conditions, but they're just not taking in enough calories. So it's important to try to tease out which category a patient falls under in order to give the appropriate evaluation and treatment. When you are evaluating a patient with malnutrition, like any patient, you want to get a detailed history and physical exam. Again, screening for those other chronic medical conditions that could be contributing to malnutrition, a history of what their losses are, vomiting, diarrhea, and for sure, you want to get a good diet history to see if they're actually getting sufficient caloric intake. You want to be using the correct growth chart. So it's the WHO growth chart for patients who are under 2, and then switch to the CDC growth chart when they're over 2. If it's a former preemie, taking a look at the premature growth chart as well. For patients with malnutrition, very rarely do you actually need lab tests. So most of the time, you're just going to be able to manage and evaluate these patients based on the history and physical exam alone. But in certain select cases, based on the history that you're getting, you may consider getting a CBC to see if the patient's anemic, electrolytes if you're concerned for dehydration, potentially based on the history that you're getting, doing celiac screening and thyroid function tests. But again, in the vast majority of patients, this is not needed. So it's not standard to screen for that for any patient with malnutrition. Maybe a urinalysis to look for renal tubular acidosis, but again, very rare. Stool tests, if you are getting a history that maybe is concerning for malabsorption and micronutrients, potentially for patients who are extremely selective in their eating and maybe only eat from 1 or 2 food groups. Other considerations for the picky eaters may be thinking about, do they have abnormal anatomy that could be causing this? Do they have some oropharyngeal dysphagia where they can't coordinate swallowing that's limiting their ability to have sufficient intake? And finally, allergies can be a consideration as well. We do see sometimes that, for example, patients who are autistic and nonverbal, they may be extremely selective in their eating, and everyone thinks that it's behavioral, but sometimes it can actually be undiagnosed EOE if we do an endoscopy, if the patient's really having severe failure to thrive and we do further workup, that's not an uncommon scenario. Red flags that would make you more likely to order lab tests and do additional investigation would be patients with weight loss. So some patients may be very small, but if they're tracking along their own curve, the whole family is small, that's not necessarily a red flag. But in a child who's growing taller but losing weight, that's for sure going to be a red flag that should prompt more workup. Any patient with prolonged and bloody diarrhea is going to warrant more of a workup. And any patient that has developmental delay in failure to thrive should prompt further workup as well. A useful tool for our patients who have special health care needs. So, for example, patients who are wheelchair bound, and it may be difficult to assess their nutritional status, you can measure a mid upper arm circumference. We all usually have these tape measures in the clinic, so this is something that's pretty easy to do where you can measure from the top of the shoulder to the bottom of the elbow and take an average and then measure the mid upper arm circumference. And you can look online for the reference values to determine whether a patient is malnourished or not. For any hospitalists, if you're managing a pediatric patient with malnutrition on the inpatient side, you're going to want to target a goal calorie of 50% more than the basal requirement. So, for example, a typically developing 1-year-old child requires 100 kcals per kilo per day. So, if you have a patient with malnutrition on your service, you're going to want to target a caloric goal of 150 kcals per kilo per day. While you're doing this inpatient, you're going to want to be monitoring for refeeding syndrome. Giving thiamine can help prevent the development of refeeding syndrome. You can start a multivitamin, including iron for patients. And if you have the option to involve a dietitian, that can be very helpful for inpatient management of malnutrition. When you're seeing a patient on the outpatient side who's having poor weight gain, some things that you can recommend for infants is going to be frequent feedings. And addition of cereal is a pretty easy way to help add more calories for infants with poor weight gain. For toddlers, you're for sure going to want to assess their milk and juice intake. This is often going to be the culprit of poor weight gain in a toddler is when you take a dietary history, you find out that they're consuming way more milk than they should for their age. And just by reducing their milk intake, you'll see that their food intake is going to increase. Juice as well can be very filling. That's for sure something you want to counsel parents to minimize for children with poor weight gain. Also, avoiding grazing. So, a lot of times parents may buy pouches or be constantly giving snacks in between meals, and then they'll say that their children, when they sit down for meals, are not eating. But of course, if they have a whole pouch right before a meal, they're not going to have an appetite for a meal. So you want to make sure that parents are scheduling meals and snack times and avoiding grazing in between. Some calorie boosters that you can recommend are olive oil. So adding a tablespoon of olive oil to anything that parents cook. If they make mac and cheese, soup, just adding olive oil is an easy way to add healthy fats. Peanut butter, if patients like peanut butter, that can basically go on anything and add healthy fat calories. Making sure that parents are using whole fat dairy products, so nothing low fat, nothing skim. There are even some yogurts that have additional fat that parents can buy if when they're in the grocery store, just checking food labels and trying to pick the highest fat content products. Cream cheese is a healthy source of fat. Any dairy product that's high in fat and protein is going to be helpful for these patients. If they like cheese, adding that to crackers, heavy cream, butter, hummus, mayo, sour cream, adding more meats and avocado are all helpful strategies. Sometimes we do end up starting appetite stimulants for our patients. This is going to be for patients who may be are not so picky, but parents will say that when they sit down for a meal, they just eat very small quantities. So that can be helpful. It's a relatively safe medication. The main side effect can just be drowsiness. So often we'll counsel that parents give it before bedtime and before nap time. Ideally, it can be dosed 3 times a day before meals if patients aren't having the side effect of drowsiness to have its full effect. Megace is another appetite stimulant that's relatively safe to use as well. If patients are having the side effect of sleepiness from cyproheptadine or periactin. Sometimes high calorie shakes like Pediatric can be used, although I will say that generally I prefer to use an appetite stimulant for a patient who's really having poor weight gain as opposed to a high calorie shake because a high calorie shake for a picky eater may actually worsen their selective eating. And now it makes them want to eat even less because they'll just more easily drink Pediasure and will be less likely to eat food. So when you're thinking about an extra strategy, say you've gone through all the high calorie boosters and your patient's still not gaining weight well, think about starting an appetite stimulant before doing a high calorie shake. But you can also counsel parents to make their own high calorie shakes, and then they have more freedom in terms of what ingredients they're putting in and can make them more varied than just Pediasure, which does have a high sugar content. You can recommend using whole milk, bananas, heavy creams, and peanut butter to make high calorie shakes at home. And a last resort, and it is sometimes needed in patients, is to consider tube feeds, especially in patients with special healthcare needs. And that's something that you want to talk about with families is definitely not a failure on their part. But sometimes for a patient, that's just what is needed to ensure that they have sufficient caloric intake. And then you can keep working on feeding by mouth, but at least you can make sure that patients are getting the nutrition that they need. So finally, I'll just go over some general advice that we can give to parents of picky eaters. Um, and just general dietary advice for patients with an ideal body weight. So, for the picky eater specifically, you want to counsel parents that they shouldn't be using foods as a reward to finish a meal. So, they should avoid saying that if you eat your salad and your meat, then you get ice cream, because then what kids will understand from that is that salad and meat is bad and ice cream is good. So instead, this is the meal and this is dessert. And regardless of whether you eat or you don't eat, this is the order that we have our meal in. And one type of food isn't better than another. You want to try to provide the food that patients are picky for frequently. Try preparing it in different ways. You want to create a positive mealtime environment and also avoid creating bite rules that make the environment at the table very stressful. Um, just in the interest of time, I'll move forward a little bit, but just one point on this slide is that if you do have a very picky eater, one thing that you can recommend that most kids will eat is Cheerios. So if kids are willing to eat nothing but Cheerios, at least you know that they're getting some micronutrients and vitamins from eating Cheerios. A few more pieces of general dietary advice. Patients should avoid skipping breakfast. You want to sit down for family meals, no screens during meals. You want to have a well balanced, varied diet. So, parents may ask about probiotics. Should they start a multivitamin? And the answer is maybe there's nothing wrong with a probiotic or a multivitamin, but the best way to stay healthy is just to eat a well-balanced and varied diet. You may be familiar with the 5-2-1-0 rule, so 5 fruits and vegetables per day, no more than 2 hours of sedentary media daily, and at least 1 hour of physical activity daily, 0 juices or sodas. Just to finish off, some additional tips for parents. So, encourage healthy food choices early on because what you do from an early age will help your child establish good lifelong dietary habits. In general, children's bodies do a good job of controlling their intake. So, if a child doesn't want to eat anymore, it may be because they're full. So, forcing them to eat more is not necessarily the right thing to do. A child-sized portion is about a quarter to a third of an adult portion size, so something important for parents to remember. And not all children are the same in terms of their calorie needs. One child who's very active may need more calories than another. And just one final point, plant-based beverages. This is a subject that is coming up more frequently, that parents may choose to use almond milk as opposed to regular milk, thinking that that may be a more healthy alternative for a child because it's plant-based, but these are not nutritionally equivalent to cow milk, and it's important to discuss that with your pediatrician. So, thank you all again for listening tonight. My name again is Daphna Katz. This is my email address. I'm happy to see any patients that people have with poor weight gain, obesity, prematurity and feeding issues, G-tubes, or if you want to just email me with any questions at any time, I'd love to hear from anybody.
Right. Thank you, Dr. Katz. Great presentation. I'm going to just share my screen for the code. And while this is up, does anyone have any questions for Dr. Katz? Oh, it looks like Dr. Yong Kim has a question. Any thoughts on intermittent fasting for kids/teens?
I personally feel pretty strongly that I would not recommend intermittent fasting for kids or teens. I think it's very important for kids to be eating regular meals at scheduled meal times. I think that intermittent fasting for especially for children can end up um, resulting in changes in their or sorry, can end up resulting in overeating and binge eating and result in unhealthy eating habits. So I definitely don't recommend that for children.
Then it looks like Dr. Curlin Vassell says, what about checking insulin level when doing obesity labs?
So that's a good question. The labs that I included in the slide, so the fasting, just a random plasma glucose and the hemoglobin A1C, those are all the recommendations from the AAP obesity guidelines on the main labs to check. I think if you wanted to know more about the insulin level, it might be a good question for an endocrinologist, but at least for the basic screening labs for prediabetes, it would be those three.
Oh, Dr. Do you see that, Dr. Katz, in the chat?
Yeah, I think then that would be a good patient to refer to endocrine for further evaluation. But then that may also be a patient, if they are obese and they have elevated insulin, they would be good to consider for using metformin.
All right. Thank you again, Dr. Katz. There are, oh, there you go. There's another question. I'm just going to read it for the recording. Among the several GLP-1 inhibitors, is there one you would recommend?
I would recommend using probably one of the ones that is weekly dosing as opposed to daily dosing. I think that's the main difference. Like liraglutide is going to be a daily injection, whereas Wegovy is going to be a weekly injection. So not that one is necessarily more effective than the other one, but I think just for patient adherence, it's easier to do a weekly injection as opposed to a daily injection. But they all have a similar mechanism of action and efficacy.
Yes, if there are no more questions, thank you, Dr. Katz. Appreciate your time, and thank you everyone for joining the pediatric webinar series.
Thank you very much.